everyone, and welcome to a new session of clinical pharmacology and drug therapy. Today, we are going to speak about important fundamental topics in clinical pharmacology, the autonomic nervous system. We are going to cover five main parts in autonomic nervous system, and it's very important topic in pharmacology, clinical pharmacology. So in order to understand the pharmacology in general, we need to start with the pharmacokinetic, pharmacodynamic, which is already covered. The second unit, important unit, which it's like consists of several chapters, will be the autonomic nervous system. The autonomic nervous system, we have several parts. Part one will be a principle and introduction to the autonomic nervous system. The second part will be cholinergic agonist. Part 3 will be cholinergic antagonist. Part 4 will be adrenergic agonist, and final part 5 will be adrenergic antagonist. Okay, let's get started. Okay, the pharmacology of autonomic nervous system. We are going to speak about the nervous system, which is consist of two main parts: the central nervous system and peripheral nervous system. The peripheral nervous system, we have two parts there. We have autonomic nervous system, ANS, and then we have somatic nerve and the somatic system. The autonomic nervous system considered like involuntary system. However, the somatic system considered like voluntary system. Speaking about autonomic nervous system, we have three main parts. We have sympathetic system, we have parasympathetic system, then we have enteric system. So we have three main parts in the autonomic nervous system in our topic for today. We have sympathetic, so parasympathetic, and enteric system. Regarding the sympathetic system, what type of neuron we have there? For sympathetic system, we have adrenergic neuron. This system released norepinephrine mainly with a small amount or small part of epinephrine. So the main mediator in the sympathetic system will be norepinephrine. Regarding the parasympathetic system, the neuron responsible for this system called cholinergic neuron. And this cholinergic neuron release a neuromediator called acetylcholine. The final part, the third part, will be enteric system. We have this maybe a specific discussion about the enteric system. Okay, in order to understand the autonomic nervous system, first of all, we need to differentiate between two main neurons in the central nervous system to the spinal cord and brain. The first type of neurons called efferent. Efferent neuron carry the sensory information from the peripheral tissue to the central nervous system, transmitting the stimuli like pain, touch, temperature, and pressure for processing. So from peripheral to the central nervous system, the efferent neuron. The efferent neuron here. So as you can see, the efferent neuron is the response of the central nervous system. Carry the motor commands from the central nervous system to the muscle glands and initiate controlling function as a muscle contraction and secretion. So the efferent neurons carry the sensory effects from the peripheral tissue to the central nervous system. On the other hand, efferent neuron carry the motor commands from the central nervous system to the muscle, glands, and other organ in our body. Okay, let us speak about the autonomic nervous system part and division. Okay, as you can see here, the main maybe function start from peripheral organs and tissues, and the peripheral organ and tissue send the sensory neuron related to the pain, temperature from the peripheral tissue to the neurons, and through the afferent neuron, this will bring the information to the central nervous system. You can see it there. So then the central nervous system responds by the motor sensory. Okay, the efferent neuron will send the motor neurons response to the peripheral nervous system. So we have efferent neuron carry the sensation from the peripheral to the central nervous system, And the central nervous system will respond through the efferent neurons, through the motor neuron by maybe muscle contraction and or secretion or gland secretion. Regarding the central nervous system, here we have the nervous system in general. We have central nervous system, then we have peripheral nervous system. Okay, for the peripheral nervous system here, we have the brain. We talk about the brain stem and spinal cord. Regarding the peripheral system, we have two main parts: somatic and autonomic nervous system. Okay, in the autonomic nervous system, here we are speaking about autonomic nervous system. We have the sympathetic nervous system, as you can see, and the abbreviation SNS, sympathetic nervous system, SNS. Then we have parasympathetic system, PNS. Then we have enteric system. So with the autonomic nervous system, we are speaking about three main parts: sympathetic, parasympathetic, and enteric. Okay, so this slide here summarize all the activity through our session for today. For example, you can see here we start speaking about the receptor or the autonomic nervous system. Here, autonomic nervous system. Here I refer you to the first session, first lecture about pharmacodynamic. So it's very important to review the pharmacodynamic record or session or like lectures before we go in depth in this lecture here. So as you can see here, the autonomic nervous system affect receptor, and we have several type of receptor. As you can see here, we have cholinergic receptor, and we have two main type. We have muscarinic receptor and nicotinic receptor. So muscarinic receptor, abbreviation for this receptor, we have M. Then we have nicotinic receptor, the abbreviation N. So we have M for muscarinic and N for nicotinic. Regarding the adrenergic receptor, we have alpha receptor, then we have beta receptor. The purpose also of these images here to remind us in the autonomic nervous system, we have something called G protein, G types. So as you can see here, we have GQ protein, and the GQ protein activate phospholipase A, phospholipase C, and this will maybe activate the IB3, inositol triphosphate, and deacylglycerol DAG, and this will activate increased level of calcium and activate protein kinase and cause biological response here. Okay, biological response. So what we have on the others, maybe on the second part, we have another type of protein. This type of protein called GS protein or GI protein. GS and GI protein, when this activated, this will lead to increase and activate adenine cyclase AC and increased level of cyclic AMP, and this will activate protein kinase A. As you can see here, we have two different type of protein kinase. We have protein kinase C, and then we have protein kinase A. We need to be familiar with this type of protein. Okay, regarding to the receptor here, someone may ask, okay, what type of receptor here is some example here. We have alpha 1 A receptor, alpha belong to the adrenergic. We have alpha 1 A receptor, for example, and this receptor binding to the G protein, GQ protein. So now we understand how alpha 1 receptor work on the molecular level by working on the IB3 DAG and increase activate level of protein kinase C. Speak about beta receptor. Beta receptor work on GS protein, and we have GS protein here. So we can speak about the activation of adenine cyclase, adenine lead cyclase, cyclic AMP, and protein kinase A. And then we have the consequences. What about nicotinic receptor here? So you can look on the nicotinic receptor here. The nicotinic receptor is like cell membrane receptor, and the number one. Number two, nicotinic receptor considered, as you can see here from the image, nicotinic receptor considered like ligand-gated ion channels. When the acetylcholine bind to the receptor, will activate the receptor and will activate. Let me do something here. will activate the receptor and open sodium channel to enter the cell, and then we have consequences. In order to understand these steps here, we need you to refer you to the pharmacodynamic lecture for more details. For clarification here, when the acetylcholine bind to the nicotinic receptor, will open sodium channel, allow sodium to influx inside the cells and cause depolarization action potential, and mostly demonstrated by skeletal muscle contraction. Okay, here we are going to speak about two main concepts, control our life and demonstrate in our daily life. The first concept called, I prefer to go the easy one for us, rest and digest. So this is the body language when you're relaxing, eating food, watching TV. So our body will be relaxing, the heart rate will be decreased, the breathing will be slow, the pupil will be constrict. We have more blood flow to the digestive system because we need to relax and digest the food. We have energy storage will be encouraged to storage glucose and other nutrients. Digestive system will be activated to assist with the processing food and absorption of nutrients. So this is the happening during relaxation, the state of relaxation. The parasympathetic system will be activated, PNS will be activated, and you can see here during rest and digest, during sleeping, for example, during eating, sitting at home, relaxing, the heart rate will be decreased, slow breathing will be slow, pupils, your iris will be constructed here, so you have smaller pupils. Blood flow to digestive system will be more because we digest and eating food. Okay, so moving to the opposite concern here, the opposite situation, fight or flight. So this one here, when we face dangerous things, when you walk, for example, on the street and you suddenly heard a noise, a crash noise behind you, and you thought there's a car approaching you suddenly, and you jump to the pedestrian. And in this case, when you hear this sound and jump to the pedestrian because you thought something going to hit you quickly, we call this one fight or flight. The same situation will be applied when someone walk on the wood and he or she heard like a sound of wild animal, and they discover this animal tried to attack them. So this one, fight or flight. The person will what happened there to the person on the walking on the street or walking on the wood. So you can see there, the heart rate will increase, our breathing will be increased, our pupil will be open in order to see more. For example, blood flow will be redirected to the important organ, to the muscles, to the brain. We need to take a fast decision. For example, we need more energy to our muscles to get ready to flight or fight, to escape or fight. So also, do we need to eat in this situation? Do we need to use the bathroom? No. So we have slow function of digestive system and urinary system. So again, during fight or flight, heart rate increasing, we have increasing respiratory rate, pupil dilation could be like open the eye, we call this one mydriasis. Then we have redirected the blood flow to the vital organs such as brain and heart and muscles. So we need this one, maybe energy there. We need this blood flow. The glucose will be provided to provide more energy. We have slow digestion and slow urination. Okay, this slide here is very important, and part 3, if you remember that, when we have autonomic nervous system, we have parasympathetic, then we have sympathetic, and the third one will be enteric system. And the situation with the enteric system, we don't have only the parasympathetic, sympathetic, and the enteric system. When you speak about the stomach, when you speak about the intestine, the colon, we don't have only adrenergic, cholinergic. We don't have only sympathetic and parasympathetic. We have a lot of mediator there. So for this reason, we call the mediators, all these mediators in the brain, we call this component like a gut brain. So the gut brains, as you can see here, we have mediators, we have receptor in the GI system, gastrointestinal system. GI stand for gastrointestinal. So as you can see here, we have several mediators there. We have acetylcholine, we have gastrin, we have histamine, we have serotonin, 5-HT, we have motoline receptor, we have the norepinephrine, we have substance B, endothelin, bradykinin. Another part of mediator we have in the gut, we have VIB, vasoactive intestinal peptide. We have somatostatin, cholecystokinine, prostaglandin, nitric oxide. We have ghrelin. Then we have neuropeptide Y. So you can see here a list of mediators, not only acetylcholine and norepinephrine. So we don't have only acetylcholine and norepinephrine belong to the parasympathetic nervous system and sympathetic nervous system. We have a lot of mediator there. So as you can see, a lot of mediator involved in the gut, and for this reason here, because we have a lot of mediators in the GI system, we call this one gut brain. So because we have a control system under GI gastrointestinal from the beginning to the end of the GI tract. Okay, someone may ask, okay, what type of effect? For example, here we need to remember the receptor binding to, for example, in the GI system. As you can see here, we have acetylcholine or acetylcholine. We have M receptor stand for muscarinic. We already covered that. Then we have N stand for nicotinic. So in the GI system, we have acetylcholine as a mediator. Then we have receptor M and N. Gastrin, we have CCK receptor, and all these abbreviation available here for CCK and other receptor. Okay, CCK stands for cholecystokinine B receptor. We have histamine H2 receptor. So histamine bind to the H2 receptor. Then we have serotonin receptor bind to the serotonin 3 and serotonin 4 receptor in the GI system. Motoline bind to the motoline receptor. Norepinephrine, we have several type of receptor, especially alpha 1, alpha 2, and beta 2 receptor. Substance B bind to the neurokinin receptor 1. Vasoactive peptide bind to the VIB receptor. Again, continue to speak about the receptor. We have somatostatin receptor bind to the SSTR receptor. Cholecystokinin or kinin, we have the CCK receptor. Then we have prostaglandin receptor. Then we have the nitric oxide receptor through the GC receptor. GC receptor stands for guanylate cyclase receptor. Then we have ghrelin receptor, neuropeptide, endothelin receptor bind to the ET receptor. The final one will be bradykinin receptor B2 receptor. Okay, let's just recap what we have mentioned from the beginning until now. We start talking about the nervous system consists of two parts. Speaking about central nervous system, autonomic nervous system. Then we move to the two concepts of fight or flight and rest and digest, and we explain that. And then we go to the autonomic nervous system to discuss three main parts: sympathetic, parasympathetic, and enteric system. With the sympathetic, parasympathetic, we discussed what type of receptor do you have there, and with the brief mentioned, we discussed the muscarinic receptor, nicotinic receptor for parasympathetic. Then we discussed we have alpha and beta receptor for the sympathetic system, and the last one was the guts brain, and the reason we have brain in the guts, we have brain in the gastrointestinal system, because we have a lot of mediator there and involved in the controlling function and malfunction. When you have disease, for example, when you have irritable bowel syndrome, serotonin receptor will be involved, the dopamine receptor will be involved, several mediator will be involved. So we can see here we have it's like they are trying to approach what happened in the brain. They said in the GI system we have gut, we have another brain in the GI system. Okay, now let us speak about the autonomic nervous system and start building the information for autonomic nervous system. We need to remember the parts, the mediators, the ganglia, all these receptor, and we can go step by step. Okay, so we have here schematic, schematic or like images or like figure. As you can see here, we will start with the brain. We have brain. Then we have the spinal cord. Uh, in the brain, we have cranial nerves, several cranial nerves. We have 3, 7, 9, and 10. And this will be responsible for parasympathetic system. Then we have sacral neurons for the neuron S2 to 4. And then we have another part, thoracic and lumbar. So here we are talking about 4 main parts. Number 1, cranial. Number 2, sacral. And these 2 main parts considered belong to the parasympathetic and somatic. And then we have thoracic and lumbar. Okay, so you can see here the cranial nerve responsible for parasympathetic system, and we have preganglionic neurons, and this neuron release acetyl or acetylcholine. So as you can see here, the parasympathetic branch or parasympathetic part, preganglionic neuron release the acetylcholine. Okay. Okay, so you can see here this preganglionic neuron releasing acetylcholine interact with the ganglia here, and the main receptor in the ganglia, nicotinic receptor, and this nicotinic receptor release acetylcholine to bind to the muscarinic receptor on the smooth muscles and the endocrine and the cardiac muscle and a nerve terminal. So you can see the pathway here for regarding the preganglionic neurons releasing acetylcholine, activate nicotinic receptor in the ganglia. Then we move to the postganglionic neuron here. The postganglionic neuron release acetylcholine and activate muscarinic receptor. So this muscarinic receptor could be available in the smooth muscles, in the gland cells, in the cardiac muscles, and the nerve terminal. Okay, another important part here we have acetylcholine through the neurons directly, maybe send the neurons directly to the skeletal muscles and connect to the skeletal muscle through the nicotinic receptor. So as you can see in this somatic neurons, somatic part, we don't have ganglia. So in the somatic skeletal muscle, we don't have ganglia. We have neuron coming from the spinal cord directly to the skeletal muscles, and the receptor between the skeletal muscle and the neurons, we call this one nicotinic receptor. We have another name. We have motor, we have neurons and motor neurons, then we have muscles, and the connection between the muscles and the neurons, we call this one motor end plate, or another name, we have neuromuscular junction. We have nerve connected to the muscle, and we call this one junction. So we call this one neuromuscular junction. So another name here, neuromuscular junction, the connection between the neurons, the muscles, and the junction. So we call this one neuromuscular junction. We have the neuron here with the several branches. You can see it here with several branches. Then we have the connection, nicotinic receptor. Okay, then we move to the muscles. If you move to the muscles here, I will go with another color here, for example. So we have here the skeletal muscle. This one, nicotinic receptor. This is skeletal muscle. This is the neurons. So this connection here, we call this connection neuromuscular junction. So now we understand what we have there for neuromuscular junction. Okay, moving to the next step here. So we already discussed the parasympathetic system and somatic system. What happened there? We discussed the 2 type of receptor there in muscarinic receptor and nicotinic receptor. Okay, so moving to the another part, which is a sympathetic system, as you can see here, if you will scroll a little bit. So we have from the thoracic and lumbar, we have preganglionic receptor, short preganglionic receptor in the sympathetic system. If you look on the parasympathetic system, the preganglionic neurons long. Okay, on the other hand, for the sympathetic system, okay, for the sympathetic system, you can see here the preganglionic is short and the postganglionic is long. Okay, this is a sympathetic system. Okay. Okay, so you can see here we are speaking about sympathetic system, sympathetic. So in the sympathetic system, we need to understand we have short preganglionic neurons. The question here, what type of neuron do you have in the preganglionic neuron in general? So the main mediator in the preganglionic neuron will be acetylcholine. Another question, what type of receptor do we have in the ganglia? We have nicotinic receptor, NR. All ganglia we have NR. So the main receptor in the ganglia NR. The question, another question, what type of receptor we have in the adrenal medulla? Nicotinic receptor. So we have nicotinic receptor in the ganglia. We have nicotinic receptor in the adrenal gland. We have nicotinic receptor in neuromuscular junction. So the question here, which of the following maybe represent the location of nicotinic receptor? I will repeat it. Which of the following represent the location of nicotinic receptor? We have ganglia, we have adrenal medulla, we have neuromuscular junction. So we have three main places for the nicotinic receptor. Ganglia, ganglia. The second one will be adrenal medulla. The third one will be neuromuscular junction. Okay, speaking about sympathetic nervous system, very important topic for us, and we'll take like a separate lecture to speak about sympathetic nervous system. Okay, so you can see here from what we have, as you mentioned, we have short preganglionic, we have long postganglionic, and the sympathetic nervous system. Speaking about parasympathetic, the preganglionic is long and the postganglionic is short. Another maybe differences between the two systems. So what we have here, I will start with the most popular one, then we move to another, maybe the less popular. I will start with this one, the most popular one in the sympathetic nervous system. You can see here we have short preganglionic, release acetylcholine, stimulate nicotinic receptor in the ganglia. Then after stimulate this nicotinic receptor, this will maybe activate the neurons, the postganglionic neurons activated, and this neuron will release mediator called norepinephrine. NE stand for norepinephrine. So you can see here the NE norepinephrine belong to the sympathetic system, adrenergic neuron. The norepinephrine will stimulate alpha adrenergic receptor or beta adrenergic receptor. So here again we need to remember we have two type of receptor will be stimulated by the norepinephrine sympathetic system. We have alpha adrenergic and beta adrenergic receptor. And this receptor available in the smooth muscles, in the gland cells, cardiac muscle, and nerve terminal, very similar to what we have there. So could be available in the same organs. So in the smooth gland we have acetylcholine, we have norepinephrine. In the heart we have norepinephrine and we have this acetylcholine. Okay, moving to the next part of the sympathetic nervous system. Next part of the sympathetic nervous system here, we have norepinephrine, and we have another mediator called dopamine. Norepinephrine stimulate the alpha-1 receptor and dopamine stimulate D1 receptors, dopamine receptor. And here we talk about the kidneys and the renal vessels and renal blood vessels. And the kidneys, renal blood vessels, we have two main type of receptor. We have alpha-1 receptor and then we have D1 dopamine receptor. Okay, in this slide here we are talking about Receptor distribution, what type of receptor we have in each organ or each cells or tissues. As you can see here in the what we have, we start with the smooth muscles. In the smooth muscles we have M3 receptor, then we have alpha 1 receptor, B2 receptor. I will remind you, M stands for muscarinic, that means this belong to the acetylcholine. Alpha belong to the adrenergic, and beta belong to the adrenergic system. Acetylcholine belong to the parasympathetic. Acetylcholine belong to the parasympathetic nervous system, and adrenergic belong to the sympathetic nervous system. So this one may be like a simple category for the smooth muscles. Someone may ask, okay, what do you mean with the smooth muscles here? Mostly we are speaking here about important things. Speak about important things here. The smooth muscles here, mostly we are speaking about something called non-vascular smooth muscles. Okay, so here we are talking about, when we speak about smooth muscles, we talk about non-vascular smooth muscles. We have three types of receptor. M3 receptor, muscarinic receptor, belong to the acetylcholine cholinergic receptor. Then we have alpha 1 beta 2 receptor, belong to the adrenergic sympathetic nervous system. Okay, again we need to understand the pharmacodynamic before we maybe start learning the autonomic nervous system. As you can see here in this chart, we have what type of G protein will be affected by this receptor. You can see muscarinic 3 activate GQ protein. On the other hand, alpha 2 activate the GQ protein. Here we have GS protein. Okay, so for the GQ will activate phospholipase C. GQ will be activate IB3 and DAG. On the other hand, beta 2 will inhibit. You can see the minus here. Beta 2 will inhibit myosin light change. Okay, so beta 2 increasing cyclic AMP inhibit myosin light change, leading to the relaxation. On the other hand, alpha 1 GQ activate GQ protein, increase activity of IB3 and DAG, increase level of calcium, but it's very similar between M3 and alpha 1, and the result will be contraction. So what we have here, we have contraction, and here we are talking about longitudinal smooth muscle cells. So we have we need also to differentiate between two type of smooth muscles. If you speak about the colons or the intestine, for example, if you speak about the intestine or the colons, in the colons we have something called longitudinal muscle. This is longitudinal muscles. Okay, longitudinal muscles. And if you talk about the colons here, then we have another one of the colons. Then at the end we have the anus and the rectum. Here we have sphincter. The type of muscle here will be circular muscle. This type of muscles here in the colons wall, we have something called like longitudinal muscles. So what happened here, we need to remember, we have two type of muscles available in the GI system. We have longitudinal muscles, and our receptor, our mediator, will cause contraction. So stimulate muscarinic receptor, stimulate alpha receptor will lead to the contraction. However, stimulate beta 2 receptor will lead to relaxation. So we need to remember that accordingly. So alpha 1 M3, alpha 1 adrenergic muscarinic receptor will lead to the contraction, here. However, this will lead to the relaxation by stimulating beta 2 receptor. Someone may ask, where is the location of these smooth muscles? We have some example for that. You can see here the smooth muscles available in the gastrointestinal system. the smooth muscle available in the genitourinary system, the smooth muscle available in the bronchi or on the lung. So we have smooth muscles. And what type of smooth muscle will be activated? Longitudinal smooth muscles that mean muscarinic receptor. So if you activate muscarinic receptor, the clinical results will be contraction, will be spasmodic, will be spasm in the GI system, will be colic pain, genitourinary system, will be bronchoconstriction, bronchospasm. So muscarinic receptor cause bronchospasm in the GI system, in genitourinary system, and the bronchial tree. Okay, speaking about the pancreas, we have M3 receptor in the pancreas. In the heart, we have beta 1 adrenergic, we have M2 muscarinic receptor. We need to remember that M2 receptor will work on the GI protein. GI protein mean inhibitory protein. B adrenergic B1 beta 1 receptor activate GQ receptor, and you can see the activation in the Q receptor lead to the contraction. So the situation will be applied similar to the heart. So you can see here by GQ receptor activate IB3 D-acylglycerol DAG. Okay, then the D-acylglycerol increased level of calcium. On the other hand, we have GI decreased cyclic AMP. Okay, beta 1 receptor in the heart lead to the contraction through the increased level of calcium. However, M2 receptor activate GI protein, decrease cyclic AMP, activate potassium channels, and this will lead to the heart rate, decreased heart rate, and decreased contractility. We can call this one bradycardia, and negative effect of the heart. So the question, what is the effect of acetylcholine on the heart? So you can see here acetylcholine activate M2 receptor in the heart. Acetylcholine slow heart rate. What is the effect of epinephrine on the heart? Effect of epinephrine on the heart and norepinephrine. So you can see here epinephrine and norepinephrine stimulate beta 1 receptor in the heart, increased level of calcium, increased contraction, and increased heart rate. So we have two opposite effects on the heart. Muscarinic, acetylcholine slow heart rate. Now we understand the mechanism. Then we have epinephrine, norepinephrine work on the GQ, calcium, and increased contraction of the heart, increasing heart rate also. Okay, we'll continue speaking about the organs and receptor distribution. You can see here we have skeletal muscles, and the main receptor in skeletal muscle will be nicotinic receptor. Okay, let me repeat this one. Regarding the nicotinic receptor, you can see here the skeletal muscles. We have skeletal muscle here, and the main receptor in the skeletal muscle will be nicotinic receptor, and we call this one somatic. Somatic neurons. Then we have adrenal medulla, and the adrenal medulla we have nicotinic receptor. For the nicotinic receptor, we have two main mediators. We have norepinephrine and we have epinephrine. And epinephrine represents 80% of mediator released from the adrenal medulla, norepinephrine 20% of the mediator released from adrenal medulla. So the main mediator in the adrenal medulla will be epinephrine, and another name adrenaline. Okay, in this slide here we are talking about the autonomic nervous system and the bladder urinary system, and we will start one by one. You can see here we have the parasympathetic nervous system affect the ganglia by stimulating nicotinic receptor, releasing acetylcholine. Okay, acetylcholine stimulate muscarinic receptor on the target tissues. This is a muscarinic receptor. So muscarinic receptor lead to the activate the receptor here on the muscles, and what we have here, as you can see here, we have longitudinal muscles and M3 receptor. If you go back to the previous slide, if you activate M3 receptor and longitudinal muscle, the result will be, what do you think the result will be when you activate M3 receptor in the skeletal muscles? The result will be contraction. So we need to remember that So the result will be contraction in the skeletal muscle by activating M3 receptor. Okay, moving to the sympathetic nervous system. Sympathetic nervous system relief, the main mediator there will be norepinephrine. Okay, the norepinephrine activate what type of receptor do you have in the bladder there? We have B3 receptor. So B3 receptor stand for beta 3 receptor, and the result will be relaxation. So you can see we have opposite action on the bladder. We have opposite action on the heart. Sympathetic system stimulate the heart. The parasympathetic system inhibit the heart, slow the heart. Speaking about the bladder, parasympathetic system acetylcholine through the M3 receptor cause contraction and maybe help to empty the bladder. On the other hand, epinephrine, norepinephrine cause relaxation through a B3 receptor. It's nice to remember we have number 3 for both muscarinic and adrenergic receptor. We have B3 and muscarinic receptor for both. Okay, then we move a little bit more to see what we have in the bladder neck. We have in the bladder neck another type of receptor called alpha-1 receptor. Here it's very important to remember how many receptors we have. We have M3 receptor, then we have B3 receptor, then we have alpha-1 receptor. We have other receptor we are going to speak about later on. Okay, moving more, and if you activate M3 alpha-1 receptor, and this will lead to the contraction. Here we need to remember what type of muscle do you have in this neck here, in the bladder neck. As you can see here from the circular, we have circular muscles. So if we activate alpha-1, this will lead to the contraction of circular muscle and urinary retention. Okay. Another concept about the bladder and the prostate. As you can see here, we have external sphincter here. We have external sphincter in this part. We have external sphincter, and this external sphincter controlled by alpha-1 receptor. However, in the external sphincter here, we have motor voluntary. We have nicotinic receptor, and we have muscles. We control this muscle. We control the external sphincter for our urination. So we can release it when you need. For example, when you go to the bathroom, you release it according to your voluntary response. So as you can see here, if we clean this a little bit to see what type of neurons will so you can see here somatic system through the acetylcholine activate innervate the motor nerve, and through the nicotinic receptor, and this one considered like voluntary response. So we have internal sphincter, and then we have external sphincter. Okay, here to recap what we already covered in the bladder, we have four main type of receptor. As you can see here, we have M3 receptor, we have beta 3 receptor, we have alpha-1 receptor, and then we have nicotinic receptor. Nicotinic receptor belong to the voluntary neurons, somatic neuron. Then we have 3 receptor belong to the autonomic nervous system, and we already covered these type of receptor: M3 receptor, B3 receptor or beta 3 receptor, then we have alpha-1 receptor. So we need to remember these type of receptor distribution in the bladder when we talk about the overactive bladder, when you talk about prostate benign hyperplasia, for example. Okay, moving to the second important organ, the eye. We talk about the effect of the autonomic nervous system on the eye, pharmacological target on the eye. Here we talk about eye. As you can see, in the eye we have iris, radius. We have iris muscles, radial muscles. So we need to remember we have radial muscle, we have circular muscles in the eye, then we have ciliary muscles. So we have the iris muscles, we have ciliary muscles. So we need to remember what we have there. Okay, regarding what we have in the iris muscles, iris muscles, like when you look on the eye, we have the iris muscles like this one here, like fiber, like rods. Okay, this is the iris muscles, and this contracted by alpha. This is innervated by alpha-1 receptor. So this muscle are innervated by alpha-1 receptor. They said if you activate alpha 1 receptor in the eye, the result will be contraction. So you can imagine now, if you activate, this is the eye here, and this is the muscles, the radial muscles, and the radial muscle. Let me clean this one here. When the radial muscle is contracted, it will be shorter. When the radial muscle contracted, become more shorter, and the iris will become large. So we call this one mydriasis. As you can see here, if you activate alpha 1 receptor, this will lead to the contraction of radial muscle and this will lead to the mydriasis. And if you compare this diameter here of the iris compared with this one here, we have a case called mydriasis, dilation of the pupil. That's number one. Okay, moving to the second one, the circular muscle, because they found later on we have circular muscle in the eye. We have circular muscle. So they found later on we have circular muscle in the eye. Okay, we have circular muscle in the eye. And this circular muscle innervated by M3 receptor. M3 receptor stands for muscarinic receptor, parasympathetic system. So if you activate parasympathetic system, this will activate M3 receptor. So what happened there? So when you activate M3 receptor with this circular muscles, with these circular muscles, the result will be the circular muscle become more like tiny and small. This is a circular muscle. So you can look what we have in the eye here, become the iris become smaller. If you compare this one here, we call this one meiosis. So now we have two cases. We have alpha 1 receptor in the eye. If you this innervate radial muscles, if you activate alpha 1 receptor in the eye, the result will be mydriasis. However, if you activate circular muscles, if you activate muscarinic receptor, circular muscle, the result will be contraction of the pupil and lead to the meiosis. So we need to remember which of these medication, which of these receptor, if you activate it, lead to the meiosis, muscarinic receptor, which of these receptor cause mydriasis, alpha 1 receptor. Activation of alpha 1 receptor lead to the mydriasis. However, activation of muscarinic receptor lead to the meiosis. Regarding the last one here, ciliary muscles innervated by beta receptor lead to the contraction of ciliary muscles, and they found for this reason here we have could be used for the glaucoma, for example here. The same will be applied for the M3 receptor lead to the contraction. So we have some medications such as pilocarpine. So pilocarpine activate the receptor here. So we have several medications. We are going to cover it later on in details. So, but what we need you to remember here, we have two main type receptor in the eye. We have alpha 1 receptor. If you activate alpha adrenergic receptor, the result will be mydriasis. If you activate M3 receptor, will be meiosis. The question, what type of muscles will be innervated by the alpha receptor, will be iris radial muscle. What type of receptor will be innervated by M3 receptor, will be iris circular muscles. Okay, speaking about alpha 1 receptor located in the maybe innervate iris muscles, radial iris muscles. You can see it here, alpha 1 receptor. However, M3 receptor will innervate the circular muscles, the sphincter of the muscles. We talk about the circular or sphincter muscles. And you can see the circular muscle, M3, and the radial muscle innervated by alpha 1 receptor. Okay, alpha adrenergic receptor, we have alpha 1, alpha 2. Regarding alpha 1, speak about alpha 1 receptor. Alpha 1 receptor location will be dilator pupil muscles, innervate radial muscles. And if you activate these muscles, the result will be mydriasis or pupil dilation. The drug will activate alpha 1 receptor. A drug will consider like alpha 1 agonist. We have phenylephrine, and phenylephrine used to cause pupil dilation. Phenylephrine used to cause mydriasis and used in the clinical practice for eye examination. So for if you need to open the pupil and facilitate eye examination, we go with the phenylephrine because phenylephrine causes mydriasis. On the other hand, we have another type of receptor called M2 receptor. You can see it here. The location of M2 receptor will be in the ciliary body and the presynaptic nerve location, presynaptic nerve. And you remember that alpha 2 receptor work on the something called GI protein. That means this will lead to the inhibitory effect. So we need to remember this one. It's a very important concept. Alpha 2 receptor activate GI protein, and this will lead to the inhibitory effect. So what happened here? In the eye, we have intraocular secretion. We have aqueous humor. So this alpha 2 receptor available in ciliary body and responsible for the secretion of aqueous humor. If you activate alpha 2 receptor, the result will be inhibitory effect. Therefore, activation of alpha 2 receptor will decrease aqueous humor production and increases uvosacral outflow, reduce intraocular pressure. And we use the medication to treat glaucoma. We have brimonidine, and another group of medication belong to the alpha 2 agonist. So now we're talking about two medications: the phenylephrine used to induce mydriasis and using during eye examination, and work on activation of alpha 1 receptor. Then we have alpha 2 receptor. We have medication bromonidine. Bromonidine activate alpha 2 receptor. Alpha 2 receptor work on GI protein and decrease aqueous humor production. So this is a key word for the alpha 2 receptor: decrease aqueous humor production. For this reason, we use it for glaucoma. Okay, regarding the muscarinic receptor, we have M3 receptor, and regarding muscarinic receptor, we have M3 receptor, and this M3 receptor available in the iris sphincter, and here we talk about circular muscles, sphincter muscle and circular muscles, and in ciliary body. So M3 receptor available in the sphincter muscles and in ciliary body. And what happened here? If you activate M3 receptor, we have two results. Number one, we have construction of the pupil, and this will lead to the meiosis. So number one, construction of the pupil and meiosis. This number one. Number two will be spasm of ciliary muscle. So we have spasm of ciliary muscle, and the person become unable to focus and unable to see, and we call this one we can call it like spasm of accommodation. So unable to focusing by using their lens, for example. So two main issues: meiosis and spasm of accommodation happen with the activation of M3 receptor. Here we need to remember that. Medication used, for example, we have medication stimulate M3 receptor. We have pilocarpine. So pilocarpine cause meiosis and spasm of accommodation. We use it for you can see it here, pilocarpine used to induce meiosis. Pilocarpine reduce intraocular pressure and may be used for glaucoma, especially talking about acute glaucoma or refractory glaucoma. Another type, okay, what happened here? Do you need to sometimes use something to oppose the action of M3 receptor? Yes, we have muscarinic antagonist oppose the action of M3 receptor. Atropine will be the medication used to cause mydriasis, and atropine also cause pupil dilation. So we have some differences here. So now we have two medication cause mydriasis. We have atropine, belong to the parasympathetic system, cause mydriasis. So we have atropine, cause mydriasis, belong to the autonomic, belong to the parasympathetic nervous system. This is number one, and cause mydriasis. And we have another one already covered. We have phenylephrine, also cause mydriasis, and phenylephrine belong to the sympathetic nervous system. So we need to remember this process here. Continue speaking about the receptor as we discussed in the eye. Again, I will remind you, we have in the eye we have M3 receptor in the eye, then we have alpha 1 receptor, then we have alpha 2 receptor, then we then we went through the okay, back again. You can see alpha 1, alpha 2. Then we have beta. We have beta 1 and beta 2. Then we moving to another one. So we have three main type of receptor in the eye: M3 muscarinic, alpha 1, alpha 2, beta 1, beta 2 in the eye. So speaking about beta receptor in the eye, what happened there? What the function of beta receptor in the eye? Beta 1 receptor available in the ciliary epithelium, and when we activate this receptor, when you activate the beta 1 and beta 2 receptor, when this activated, this will increase production of aqueous humor. So increase production of aqueous humor, this will lead to the increase intraocular pressure, and this will aggravate glaucoma. This will maybe make the situation worse for glaucoma. Okay, make the situation worse here. So when you activate beta 1, beta 2 receptor in the eye, will increase the production of aqueous humor and worsening the situation due to the increased intraocular pressure. So the opposite happened there. They tried to block beta receptor in the eye. So they tried to block beta 1 receptor in the eye. We have several medications belong to the beta blocker, and the most important one will be timolol and betaxolol. So you can see it here in the text: betaxolol and timolol. So if you stimulate alpha, increase intraocular pressure. What happened if you block alpha? Blocking alpha will decrease production of aqueous humor, and this will decrease intraocular pressure. So now we have another medication for glaucoma. So if you go back, or if you like to remember, give me medication belong to the adrenergic system used for glaucoma. Adrenergic system, we have timolol. Giving medication used for glaucoma belong to the cholinergic system. If you go to the previous slide, you can see here pilocarpine. So we have two medication could be used for the treatment of glaucoma. So treatment of glaucoma, here we have list of medication. We start typing there for the treatment of glaucoma, for example here. So we already covered the timolol. This belongs to the blocking beta receptor in the eye. Then we have pilocarpine. This stimulate muscarinic receptor in the eye. So this one belong to the adrenergic, belong to the muscarinic neurons. Okay, this slide here focus on the four major family receptor here, as you can see back. So you can see four major family receptor. We are not going to discuss this four families. You can family number 1, 2, 3, 4 already covered in detail in the pharmacodynamic. But the reason of this slide here to refresh our brain, our memory about two type of receptor will be working on during speaking about autonomic nervous system. The first type of receptor will be G protein receptor. G protein coupled receptor is very important receptor. We have GQ, GI, GS, GO. Then we have ligand-gated ion channels such as a nicotinic receptor. So we have two main receptors involved in our autonomic nervous system: G protein receptor and ligand-gated ion channel receptor. We need to remember this receptor in order to understand autonomic nervous system. Again, this slide here represent our molecular life, our molecular system. What happened when you prescribe medication? What happened when the dopamine release? What happened when the serotonin release? What happened with the epinephrine release or acetylcholine release? As you can see here, we have a concept called G protein coupled receptor. So when the medication prescribed to the patient, for example, let me say we have norepinephrine. So norepinephrine will activate the receptor. We know that norepinephrine stimulate alpha and beta. We know that acetylcholine stimulate muscarinic and nicotinic receptor. We know that We have some medications such as ondansetron, for example. Ondansetron stimulate the serotonin receptor. We have dopamine receptor for antipsychotic. So we have a list of medication work on this receptor. Example here, norepinephrine stimulate alpha and beta receptor. So we have it alpha and beta receptor. So the norepinephrine as endogenous substance or as drug bind to the receptor. Okay, the receptor next step will be activate the receptor. So receptor activation. The receptor activation will activate G protein. And now we have to stop here and remember that we have several types of G protein: GS, GI, GQ, and GO. Okay, this is number one. Then we have another type of guanosine diphosphate could be transferred to the guanosine triphosphate, and here we talk about maybe specific pathways. Okay, when the G protein activated, this will lead to the release of second messenger. The second messenger, as you can see, could be adenyl cyclase, could be phospholipase C, could be guanylate cyclase, phospholipase A. We have several types of second messenger. The second messenger will activate protein kinase. Again, for protein kinase, we have protein kinase A, and then we have protein kinase C here. So when you activate protein kinase, this will affect the organs, will affect the tissues, will affect the cells through the gene expression. For example, when you talk about cortisone, or like when you talk about androgen or estrogen. Protein activation, when you talk about, for example, other type or cellular responses. So we have several, and this is our molecular life, what happened from the molecular to the organ effect. So you can see here with the receptor activated lead to the consequences of effect, and at the end we have the clinical appearance of these effect. Okay, in this slide here we need to remember the subtypes. M stands for muscarinic receptor, and muscarinic receptor belong to the cholinergic system, cholinergic neurons. I will go back to the slide. M stands for muscarinic, belong to the cholinergic neuron, and here we talk about, here we are speaking about parasympathetic nervous system. So parasympathetic nervous system, we have cholinergic neurons, Cholinoceptors Characteristics. We have several types of muscarinic receptor: M1, M2, 3, 4, and 5. But 3, 4, and 5 is very rare to be available in the practice. M3 and M4 and 5 is very rare. Therefore, we don't have it in the table here. So we have M1, very popular, M2, and M3. So we need to remember these three types of receptor. Then we have nicotinic receptor available in ganglia, and nicotinic receptor available in the muscle, skeletal muscle. So we have two types of nicotinic receptor. We have three popular types of muscarinic receptor. We need to remember the location. We need to remember the mechanism, and G protein, the major function for each of these mediator. We need to practice this one to memorizing, understand the consequences for any concept. Okay, speaking about muscarinic receptor 1, available in the neurons, available in the sympathetic system, postganglionic neurons, and this type of receptor, M1 receptor, muscarinic M1 receptor, activate GQ protein. This will increase level of IB3, inositol triphosphate. So you can see it here, inositol triphosphate, and this will increase DAG or deacylglycerol, or diacylglycerol. Okay, this is M1. Speaking about M3, so M1 and M3, both of them work on the GQ protein, so no need to repeat it. So M1 and M3, the result will be activation. M1 and M3, the result will be activation through the IB3 and DAG. Okay, speaking about M2 receptor, mainly available in the heart, smooth muscles, and neurons. M2 receptor working in the GI protein, and you can see here that if you activate GI protein, the result will be inhibitory effect. The result will be inhibit decreased level of cyclic AMP and activate potassium channel. This will lead to the hyperpolarization or relaxation. So the Inhibitory effect M2 receptor. Stimulatory effect M1 and M3 receptor. Moving to the nicotinic receptor, as we mentioned, we have two types of nicotinic receptor. We have the nicotinic receptor available in the ganglia. We have nicotinic receptor available in the neuromuscular junction. Neuromuscular nicotinic receptor in ganglia, we have the abbreviation for ganglia N, nicotinic N, nicotinic receptor in the ganglia. And this, if you activate this receptor, the result will be depolarization. So activation of ganglia lead to the depolarization. If you activate the nicotinic receptor in the muscles, M stands for muscles. If you activate this receptor, the result will be depolarization, and we can call this one, if you activated a skeletal muscle contraction. Okay, so it's very important to remember which of these cholinergic receptor lead to the skeletal muscle contraction. So will be NM. Which of these receptor lead to the activate ganglia? We have NN. So the important one here. Which of these cholinergic receptor lead to the inhibitory effect on the heart? So we have M2 receptor. So we can create several multiple choice question regarding this table here. Okay, the second table represent the adrenoceptor. Adrenoceptors here we talk about the adrenoceptor, we talk about adrenergic. Here we talk about sympathetic nervous system. And you remember that we have epinephrine and norepinephrine as main mediator. So epinephrine main mediator followed by norepinephrine. Then we have another one called dopamine. So we have three main mediators related to the sympathetic nervous system. Epinephrine, the major, followed by norepinephrine and dopamine. Three main mediators. For this reason here, the receptor belong to the adrenoceptor characteristic sympathetic system, adrenergic receptor. We have alpha 1, alpha 2, beta 1, beta 2, beta 3, dopamine receptor 1. So you can see we have several types of receptor here. Start talking about GI protein. So the only list of the receptor here, GI protein working at the GQ. So remember, this one GQ. Okay, so M3, M1, and M3, alpha 1, these type of receptor working on the GQ receptor. So it's very important. So which of these receptor activate GQ receptor? We have muscarinic M1, muscarinic M3, alpha 1 receptor. That's great. Okay, moving to the GQ receptor alpha 1. This receptor available mainly in the smooth muscle cells and the glands, and activate IP3 deacylglycerol, increase calcium, and lead to the contraction, lead to the increased secretion. We are going to cover that, what happened there. So I will give you example. Alpha 1 receptor available in the smooth muscle cells. So alpha 1 receptor available in the smooth muscle cells. So for example, if you talk about blood vessels, we have smooth muscle cells and the blood vessels innervated by alpha 1 receptor. If you activate alpha 1 receptor, this will lead to the contraction and increase peripheral vascular resistance, and this will lead to the increased blood pressure. So now you can see if we have medication activate alpha 1 will be lead to the contraction of smooth muscles and the blood vessels and increased peripheral vascular resistance, and the end result will be increased blood pressure. So this you can see it here what we have contraction here. Okay, this is example number 1. Moving to the alpha 2 receptor. Alpha 2 receptor available in the presynaptic. Alpha 2 receptor mainly available in the nervous system more than smooth muscles. So alpha 2 receptor work on GI protein. I stand for inhibitory effect. Again, another mediators or like receptor work on GI protein. We need to remember M2 receptor and alpha 2 receptor These two type of receptor work on the GI protein and lead to inhibitory effect. So now we understand some maybe category for the G protein, GI, and GSGQ. Okay, the other will be GS, as you can see here, GS protein. So we have beta 1 receptor work on GS protein, beta 2 receptor work on GS protein, beta 3 receptor GS protein, and dopamine D1 receptor work on the GS protein. Okay. Moving to the beta 1 receptor. Beta 1 receptor, so let me clean the board here. Okay, beta 2 receptor here, if I clean it. Okay, speaking about beta 1 receptor, mainly available in two main organs. Beta 1 receptor available in the cardiac muscles, in the heart, and in the renal. This receptor stimulate the GS protein and represent by increasing the cyclic AMP. This will be activate the heart, increase heart rate, increase heart contractility, and if you talk about the kidneys, increase release of renin. So we have a process here. What type of receptor available in the heart? Mainly in the heart, beta 1 receptor. In the kidney, in the renal, we have beta 1 receptor. What is the result of activation of beta 1 receptor? Stimulate the heart, increase heart rate, increase contractility, increase release of renin. Okay, moving to the beta 2 receptor. Beta 2 receptor available in smooth muscle cells, liver, and in the heart. Beta 2 receptor work on the GS protein, increase cyclic AMP, activate, increase cyclic AMP. Okay, activate, increase cyclic AMP, and beta 2 receptor lead to the relaxation of smooth muscles and decrease gluconeogenesis, glycogenolysis. Glycogenolysis mean increased level of glucose in the blood. So when you activate beta 2, the result will be increased level of glucose due to the glycogenolysis. So in the heart, in the beta 2 activate, in the liver, in smooth muscle relaxation. So here we talk about smooth muscle relaxation. It's an important issue here to focus on. Maybe I need to go to the whiteboard and explain some important concept to remember. Okay, so the important concept regarding the blood vessels here, I would like to mention here. Let me make it smaller here, like this. Change this one, much better. So you can see what we have here, like 100. Okay, I clean it. This is the blood vessels here. Okay, so we talk about blood vessels. Okay, so they found later on we have two main type of receptor. We have alpha 1 receptor, and then we have beta 2 receptor. So this is what we have in reality in the blood vessels. So what they found later on, normally beta 2 receptor will be predominate in the blood vessel, and they found if you activate beta 2 receptor, if you activate beta 2 receptor, the result will be relaxation. And here we talk about blood vessels. That means, can we talk about vaso? Vaso stands for vessels, vasodilation. Yes, vasodilation. Okay, and this will lead to the decreased peripheral vascular resistance and decreased blood pressure. So this is what we have in the blood vessels. So if you activate beta 2 receptor, this will lead to the relaxation, vasodilation, decreased vascular resistance, and lead to the decreasing blood pressure. On the other hand, so we have alpha 1 receptor here. If you activate alpha 1 receptor, so remember alpha 1 receptor work on the GQ receptor, and this will lead to the increased calcium and contraction. That mean when we talk about contraction, so we have blood vessels contraction, we talk about something called vasoconstriction. Okay, this will lead to the increase peripheral vascular resistance and increase blood pressure. So we have balance in the normal life between two type of receptor in the blood vessels. We have it in the as alpha 1 receptor and beta 2 receptor. So let me go back to the slide again. So as you can see here in this slide, we have beta 2 receptor, and beta 2 receptor will lead to the, if you clean this one here, beta 2 receptor will lead to the vasodilation, relaxation. What do you think? Decrease blood pressure, decrease peripheral vascular resistance, and decrease blood pressure. So again, beta 2 receptor, activate beta 2 receptor will be decreased blood pressure. Beta 3 receptor, where they found beta 3 receptor available in adipose tissue, and available also we can add here a bladder. So available in the adipose tissue and in the bladder. If you activate beta 3 receptor, increase lipolysis. If you activate beta 3 receptor in the bladder, lead to the like longitudinal muscle relaxation. Okay, so then they found medication stimulate. We have medication stimulate beta 3 receptor, and this medication used for the case or disease called overactive bladder. So now we have a disease and we have a case. We have medication activate beta 3 receptor. Beta 3 receptor will be in the detrusor muscles in the bladder, and this will lead to the relaxation of detrusor muscle, longitudinal muscle, and allow the person to hold the urine for a long time without need to go to the bathroom very often. And this medication used for overactive bladder. The medication name for the beta 3 receptor mirabegron, Mybatric. Okay, so when you conclude this maybe first part of autonomic nervous system, we need to ask ourselves several questions, refresh our mind about our brain. What is the name of neurotransmitter of in the adrenergic neurons? What is the name of neurotransmitter in the adrenergic neuron? The second question, what is the name of neurotransmitter in the cholinergic neuron? And the last statement, yes or no, adrenergic and cholinergic action often complete or oppose each other. Which one is correct? Complete each other or oppose each other? Okay, this slide here, we emphasize on the function of sympathetic nervous system. It's very important to know that sympathetic nervous system is always and continually active. So we need this system to be continually active in order to maintain vascular tone. So if you, for example, if you ask someone, do you have blood pressure? Yes, we have blood pressure, because the sympathetic nervous system continually active, persist active. So we have epinephrine or epinephrine work 24 hours in our body to maintain vascular tone, to give us the normal blood pressure 120/80, and the new guidelines now talk about 120/70, for example. So again, the main purpose of that, so you can see here, number one, to maintain vascular tone, number one. Number two, central nervous system adjust response to the stressful. For example, when you have trauma, for example, when you have fear, when you have hypoglycemia, when you have intense exercise, this maybe mediator will be released. Also, this mediator will be released during fight or flight. The activation of sympathetic system will lead to the following action. Here, activation of sympathetic system lead to the following action. We need to remember all these. Increasing heart rate is very important. So when you activate, when the epinephrine or epinephrine increase in our body, the heart rate will increase, and this will enhance cardiac output and will supply more blood to the muscles and more oxygen. So we prepare ourselves for fight or flight, prepare ourselves for exercise. So increasing heart rate. Number two, so you can see here bronchodilation. Bronchodilation means dilation of the bronchial tree, expand airways to better oxygen intake. What happened with the blood vessels here? During this stimulation, the vasoconstriction will happen, increased blood pressure, and redirect the blood to the essential organs such as muscles, brain, and heart. A pupil dilation to improve vision. When you have fight or flight, we try to figure out what happened around you. So we have pupil dilation. Glycogenolysis, that means breakdown of a glycogen to produce more glucose for energy. When you have fight or flight, when you have any trauma, hypoglycemia, intense exercise, we need the energy. Sympathetic nervous system will stimulate and breakdown of a glycogen to give or release glucose and provide more energy. Again, this is comparison between two systems, between rest and digest, fight or flight. We already covered that. And you can see the opposite action between fight and flight and rest and digest. The question here, which system will be responsible for fight or flight? Sympathetic nervous system. Which system will be responsible for rest and digest? Parasympathetic system. Okay, another question. Which mediator will be responsible for fight or flight? Someone maybe will type here. Okay, I will go back. Someone will type here. I will type here epinephrine. And norepinephrine will be responsible for fight or flight, sympathetic system. Which mediator is responsible for rest and digest will be acetylcholine. And we have maybe you can see the opposite action here for heart rate, pupil, and dilation is already covered in other slide. Okay, so in this slide here we cover important reflex response happen to the human body involuntarily when someone suffers from hypotension or decreased blood pressure. So what happened in our body? So here we are talking about the consequences of decreasing blood pressure or fall in blood pressure. What happened there? So we are going to speak about that. Okay, so starting with the first step. When someone suffers from decreased blood pressure, what happened? The situation, we have a receptor called baroreceptor. These baroreceptor available, as you can see, in the heart, vena cava, and aortic arc, and available in carotid cyanosis, and this will activate the cardiovascular center in the brain. So first of all, decreasing blood pressure, activate baroreceptor activity, and this will activate the cardiovascular center in the brain. What happened next? Okay, so the cardiovascular system in the brain, will this activated in the brain? So two systems will be affected. Number one, this will increase sympathetic activity in the brain. Sympathetic activity will be increased in the brain and decrease parasympathetic activity. So when the cardiovascular system activated in the brain, this will lead to two pathways. Number one, activate sympathetic system and inhibit parasympathetic system. What that mean for us? So if you activate the sympathetic system, the result will be increased heart rate and the result will be vasoconstriction. Okay, so if you increase heart rate and the result will be vasoconstriction, what happened to the blood pressure? The blood pressure will be increased as a compensatory mechanism. So you can see the consequences start if someone suffers from hypotension, low blood pressure, decreased blood pressure, baroreceptor will be activated. Number one. Number two, the cardiovascular center in the brain will be activated, and this will inhibit parasympathetic and activate sympathetic. And number three here, so number four will be increased heart rate, vasoconstriction. Number five, the end result will be increased blood pressure as a compensatory mechanism. Okay, so in the adrenergic system, on the sympathetic system, we already presented data there speaking about the sympathetic system work as an entire unit, always active, try to keep the vascular tone, try to keep the blood pressure under control, under normal. So we have continually active sympathetic system. So what happened in the parasympathetic system? When you speak about parasympathetic system, they said we don't have like this system does not work as a unified system. They work on the as a separate independent fiber. So in the eye, they work in different from the stomach, different from the urinary system. So it's like crucial to maintain for maintaining essential body functions such as digestion and waste elimination and other system. So you can see here individual parasympathetic fiber are activated separately. So the parasympathetic system works separately. The parasympathetic system does not work as one unit, works separately. The GI system different from the elimination system, different from the other target, the stomach system or the eye. So we have different system work separately. So remember, parasympathetic system works separately in the eye, in the stomach, in the GI system, genitourinary system, and the central nervous system. So we work as a separate unit. Okay, this slide here represent the effect of autonomic nervous system, effect of autonomic system and cardiovascular system. So what is the effect of adrenergic, cholinergic neuron on the heart and blood vessels? We start with we have two systems, as we mentioned. We have sympathetic system. What happens if you activate the system? We have parasympathetic system. Then we speak about what happens if you activate this parasympathetic system. First of all, we need to remember what type of receptor do you have in the heart in both system. Then what is the effect? Start with the heart. They said in the heart we have sinoatrial nodes. This is responsible for heart rate, considered like pacemaker. Okay, so sinoatrial node responsible for heart rate. And they found in the heart we have two main receptors available in the heart. We have beta 1, beta 2 receptor. And for the receptor responsible for contractility, we have beta 1, beta 2 receptor, the same receptor. So what happens if you activate these two receptors? The result will be increased heart rate and increased contractility. So this is what we need you to remember from this, the important issue here. At sympathetic system, we have beta 1, beta 2 receptor in the heart. If you activate this receptor, this will lead to the increased heart rate and increased contractility. Okay, on the other hand, we have the parasympathetic system. We have M2 receptor, and we know that M2 receptor work on GI protein, and I stand for inhibitory effect. So if you activate GI protein, the result will be decreased heart rate and decreased contractility. So here someone may ask, what is the effect of acetylcholine on the heart? So acetylcholine decrease heart rate and decrease contractility, decrease conductancy due to the M2 receptor GI protein. On the other hand, epinephrine or epinephrine activate the heart through the beta 1 receptor and beta 2 receptor. Okay, this is in the heart. Moving to the blood vessels. In the blood vessels, here we have different type of blood vessels. We are speaking about the skin blood vessels. We are speaking about the blood vessel and the skeletal muscle blood vessels. Then we have the endothelial blood vessels. So we talk about three type of receptor in the skin and skeletal muscle and endothelial vessels. So what happened here? What do you have? In the skin, the predominant receptor in the skin, alpha 1 receptor. So what happened if you activate alpha 1 receptor? The result will be contraction of the skin blood vessels. What happened if you activate the blood vessels, the receptor in the skeletal blood vessel, beta 2 receptor? The result will be relaxation. What that mean for us? So in this case, we can type here vasodilation. Here we have vasocontraction. So you can see here in the skin we have alpha 1, activate alpha 1 vasoconstriction. In the skeletal muscle blood vessel we have alpha 2, the result will be vasodilation. In skeletal muscle also, if you remember in the whiteboard, we have alpha 1 receptor. Alpha 1 receptor lead to the contraction, but the predominant receptor in the skeletal muscle vessels, the predominant receptor will be beta 2, and the result will be vasodilation. Regarding the endothelium blood vessels, we have M3 receptor. This will enhance nitric oxide release and lead to the vasodilation. Okay, through the nitric oxide release. So now we have the concept about the heart, about blood vessels in the skin, skeletal muscle, and endothelial of cells. Okay, about study the effect of autonomic nervous system on the gastrointestinal tract, on the GI tract, stomach, intestinal colons. We have sympathetic activity, two type of receptor. We have alpha 1, beta 2 receptor. That stimulation of beta 2 lead to relaxation. Parasympathetic system, we have mainly M3 receptor. If you stimulate M3 receptor, this will lead to the contraction. We have some medication antagonize the action of M3 receptor, such as doxylamine, and this we use it as antispasmodic medication. So if you stimulate M3, this will lead to the contraction. This will lead to the spasm. So if you antagonize the action of M3, the result will be antispasmodic effect. So we have the medication called doxylamine. Okay, M3 receptor agonist. We have pilocarpine and bethanicol, and this is the bethanicol used to increase tone of the GI system. We use it in the GI system. For example, when you have paralysis in the GI system, bethanicol enhance contraction. Pilocarpine, we use it when the patient suffer from the hypersecretion, or like not hypersecretion, dry mouth, or xerostomia, and we use pilocarpine to increase secretion. Here in this slide, we are talking about the effect of autonomic nervous system and the bronchial smooth muscles. Very important concept here, because this will affect two major disease case. Will affect the COPD and will affect asthma. So we have medication belong to this group of autonomic nervous system. We have COPD and asthma. I will go back there to show you what we have. Okay, so sympathetic nervous system, and the bronchial tree, we have alpha 1, alpha 2, and beta 2, and this available in the smooth muscle wall, longitudinal muscle, lead to we don't have any effect here. If you look on the blue background, activation of beta 2, this is a predominant receptor in the bronchial tree, beta 2, the predominant receptor in the bronchial tree, and lead to the relaxation. Beta 2 receptor, alpha 2 receptor is one of these also. So we have, if you use beta 2 agonists such as albuterol, for example, beta 2 agonist, this will lead to the bronchodilation. So bronchodilation is the case here. Okay, bronchodilation. Bronchodilation is induced by albuterol. Albuterol is beta 2 agonist. Beta 2 agonist belong to the sympathetic system, and the beta 2 agonist will be available in smooth muscle longitudinal fiber in the bronchial tree. Regarding the parasympathetic activity, main receptor in the bronchial tree, muscarinic receptor, and this is responsible for the increase secretion, and activate sphincter or circular muscles. Activation circular muscles, you can see it here. Activation of circular muscle lead to the contraction. So the gray background lead to the contraction and increased secretion. Okay. So for this reason here, we can use something called a muscarinic M3 antagonist. Muscarinic M3 antagonist, we have ipratropium, and this ipratropium used for patients suffer from COPD, chronic obstructive pulmonary disease. So what is ipratropium? Ipratropium is a muscarinic M3 antagonist, belong to the parasympathetic system. Now you can see here from this graph, we have different type of receptor: sympathetic, parasympathetic, beta 2 receptor, and mainly available in the lung. If you stimulate beta 2 receptor, the result will be bronchodilation, and we have medication used for asthma and COPD called albuterol. On the other hand, we have parasympathetic system. The main receptor in the bronchial tree will be M3 receptor, muscarinic M3 receptor. If you stimulate M3 receptor, the result will be contraction and increased secretion. So to use this function in therapeutic application, we have ipratropium. Ipratropium antagonizes the action of this receptor, block the M3 receptor. And what happened there with ipratropium, when you use ipratropium, this will lead to the decrease of contraction, and this will lead to the decrease of secretion. So two important things. For this reason, this medication considered like drug of choice for COPD, chronic obstructive pulmonary disease. Okay, the next slide will speak about the next slide. We are going to speak about the effect of autonomic nervous system on genitourinary smooth muscles. Here we have two main parts, sympathetic and parasympathetic. As you can see in the bladder wall, we have beta 2, beta 3, and if you activate these beta 2 and beta 3 in the bladder, if you activated beta 1, beta 3 sympathetic adrenergic system, the result will be, we have the bladder, the result will be relaxation, open the bladder, relax the bladder. Okay, speaking about the sympathetic system, we have M3 receptor. If you activate M3 receptor in the bladder, the result will be contraction. Here we talk about bladder wall, and the patient will be unable to tolerate urine, and the patient will start suffering from urine hesitancy or urgency. Okay, moving to the next, in the sphincter, here we talk about the sphincter. We have alpha 1 receptor, and we already covered that in the picture in previous slide, the distribution of the receptor in the bladder. We have M3 receptor, beta 3 receptor, alpha 1 receptor, then we have nicotinic receptor in the bladder. I refer you to that. I would recommend you to go and review that slide about the bladder wall and sphincter. Okay, so we have alpha 1 in the sphincter, we have alpha 1. Then we have M3 receptor. So M3 receptor in the sphincter, if you activate muscarinic receptor in the sphincter, the result will be relaxation. So you can now imagine what we have here. If you draw a line like this one here in the bladder, and in the bladder here we have M3 receptor responsible for the contraction, and here we have bladder neck. Okay, bladder neck, we have contraction in the body and relax the sphincter, open the sphincter here. So what happened here in the sphincters? Make the sphincter open, and this will lead to the push the urine outside the body. So if someone suffer from, let me say, urgency, or like any case of overactive bladder, is not allowed to use this medication. For example, we try to block this medication in order to allow the patient to hold the urine, such as muscarinic receptor antagonists. We have a list of medications such as oxybutynin, tortridine. We have other medication also. So here we explain what happened there with the longitudinal muscle and with sphincter muscles for the prostate. Okay, moving to the uterus and pregnancy, we have beta 2 receptor. If you prescribe beta 2 receptor, the result will be relaxation. Beta 2 receptor result will be relaxation. And moving to the beta alpha receptor lead to the contraction of uterus. Okay, you can see M3 receptor lead to the contraction of the uterus. Okay, venous and seminal vesicles, we have adrenergic, the main receptor. We have alpha receptor responsible for ejaculation, contraction, ejaculation. Alpha adrenergic receptor. Muscarinic receptor responsible for erection. So which of these receptors responsible for erection? Muscarinic receptor. Which of these receptors responsible for ejaculation? Alpha adrenergic receptor. Okay. So this summarizes the action of the effect of autonomic nervous system on the genitourinary smooth muscles. Okay. Okay, so here we need to mention briefly about the medication. Some medication used for therapeutic benefit. For example, we have oxybutynin. We have oxybutynin here. Oxybutynin, muscarinic antagonist. We have it here. Oxybutynin try to block this receptor here. Oxybutynin, and this used for overactive bladder. Toltridine, the same. Then we have the mirabegron beta 3 adrenergic agonist. So we have agonist here. We have mirabegron beta 3. So we are talking about beta 3 receptor here and lead to relaxation, mirabegron. And here we need to add plus mirabegron stimulate beta 3 receptor, lead to the relaxation. So mirabegron and oxybutynin toltridine used for overactive bladder. So we have the case now. Give me medication used for overactive bladder. We have oxybutynin toltridine mirabegron. What is mirabegron? Mirabegron beta 3 adrenergic agonist. What is oxybutynin? Oxybutynin muscarinic antagonist. So we have it. We have different mechanism of action, but with the same clinical use, and depends on the patient. We always deal with patient, not with the disease. The next one will be with the next group of medication. I will clean the whiteboard here. The next group of medication is very important group. We have tamsulosin and terazosin. Tamsulosin considered like selective alpha 1A antagonist. Selective alpha 1A antagonist, tamsulosin. And this tamsulosin mainly used for patients suffer from benign prostatic hyperplasia by blocking alpha 1A receptor in the prostate and in the bladder neck. Then we move to the next one, terazosin. Terazosin is non-selective alpha, and terazosin decreased blood pressure. Could be used for the decreased blood pressure. Could be used for treatment of hypertension. This is one possible. I will clean this one. I will type number 1. And number 2, we could be used for patients from benign prostatic hypertrophy. So we have several group of medication here. Bethanicol, we use it for atonic bladder and for the paralysis of intestinal after surgery. So all these list of medication apply to our list here for the genitourinary system. As you can see, we have oxybutynin, toltridine, bethanicol, tamsulosin, terazosin, and mirabegron. We need to remember what is oxybutynin, what is bethanicol, what is tamsulosin, what is terazosin, what is mirabegron. Which one of these medication agonists, which one of these medication antagonists, which one of these medication muscarinic, and which one like adrenergic or beta, or like beta adrenergic or alpha adrenergic, agonist or antagonist. Okay, so we have two main important concepts in autonomic nervous system. We are going to speak about the synthesis and release of mediator, two main mediator we are going to cover in this two maybe common slide. We have norepinephrine and acetylcholine. We will start with the norepinephrine, speak about synthesis, release of norepinephrine from the adrenergic neurons. Before we go in depth there, so we need you to be familiar with this abbreviation here. NE stands for norepinephrine. TH stands for tyrosine hydroxylation. This is enzyme, tyrosine hydroxylase. Then we have COMT, another enzyme, catechol O methyltransferase. Then we have another enzyme, monoamino oxidase, MAO, monoamino oxidase. We have abbreviation alpha R, stand for alpha adrenergic receptor. Then we have beta R, stand for beta adrenergic receptor, and NE stands for norepinephrine. It's repeated for us. Okay, so I will start clicking and see what we have here. So as you can see here, the norepinephrine start from the tyrosine receptor, tyrosine as amino acid. The tyrosine enter the neurons with the co-transporter, through the co-transporter with the sodium. The tyrosine enter the cell. The tyrosine, under the effect of enzyme called TH, tyrosine hydroxylase, will convert to the DOPA. Also, DOPA will convert to the dopamine decarboxylase to the dopamine. So another enzyme, dopamine decarboxylase, will convert DOPA to dopamine. Okay, then the dopamine will enter the fascicles and convert in the fascicles to the norepinephrine. So we have dopamine as mediator for some type of neurons, and other type of neurons, the dopamine will be converted to the norepinephrine, NE. So you can see the NE inside the neurons. So norepinephrine, dopamine enter the fascicles. This is the fascicles here, and norepinephrine enter the fascicles. Okay. So now the dopamine norepinephrine inside the fascicles. What happened next? The dopamine approached to the end, to the edge of the to the preganglionic neuron. So this fascicles approach to the edge here, and fuse and maybe become one part of the preganglionic neurons. And then the next step, okay, the next step will be okay, so if you click on this one here, the next step will be, okay, so uptake. So you can see here the first step will be synthesis of mediator, synthesis of dopamine or epinephrine from tyrosine. The second step will be the fascicles start uptake the mediators and bring the mediator from outside to inside the fascicles. Okay, next. Next we have here the next step will be norepinephrine release. So you can see here the norepinephrine, if you go back a little bit here, if you go back, so we have the norepinephrine inside the fascicles. Okay, the norepinephrine, the third step will be release of norepinephrine. So you can see here the norepinephrine start releasing from the fascicles, and we can call this one exocytosis, release the content of the fascicles to outside the neurons. Okay, number 3. Moving to the number 4. Number 4, the mediator in the synaptic cleft in the gap, the mediator here, and what is the fate of this mediator? So the mediator, the first fate, the first pathway to bind to something called post-ganglionic receptor. So we call this one here, this part here, this part, and we have this part. This part we call this one pre-ganglionic receptor. Okay, pre-ganglionic neuron. Here we have post-ganglionic neuron, and we call this one like a cleft or gap. Cleft or gap. So this is the 3 parts. So pre-ganglionic neuron, post-ganglionic neuron, then we have cleft or the gap between them. Okay, so we continue here what we have. As you can see here, we have the release of norepinephrine, and the first fate, the first pathway to bind to the post-ganglionic receptor, to bind to the alpha-1 receptor or beta-1 receptor. So you can see this small receptor here. We have alpha-1 receptor and beta receptor. So we have in the post-ganglionic, we have alpha-1 receptor and beta receptor. Also try to remind us here, as alpha-1 receptor activate GQ protein and beta receptor activate GS protein. This is one pathway. What about the second pathway? As you can see here, for the second pathway, we have something called binding to the alpha-2 receptor in the presynaptic neuron. So we have 3 types of receptor: alpha-1 receptor, beta receptor in the postganglionic neuron. We have a beta-2 receptor in the preganglionic neurons. Okay, what type of G protein related to the alpha-2 receptor? You can see the GI protein here related to the alpha-2 receptor inhibitory effect. Okay, another fate. So number 1, bind to the postganglionic receptor. Number 2, binding to the alpha-2 receptor, preganglionic receptor. Number 3 will be metabolized. Metabolized, what that means? We have enzyme responsible for metabolism. We have 2 main enzymes responsible for metabolism. The first enzyme will be catechol-O-methyltransferase, COMT, and the second enzyme will be monoamino oxidase, as you can see. So if you go to the abbreviation, COMT, catechol-O-methyltransferase, and MAO, monoamino oxidase, these 2 enzymes responsible for metabolism of norepinephrine in the synaptic cleft, in the gap. So what we have here, norepinephrine will be metabolized to inactive metabolites, and this metabolite will be eliminated in the urine. This is stage number 5. So again, after stage number 5, we have another option here. Yes. So number 1, binding to the postsynaptic receptor, binding to the presynaptic receptor, metabolized by the enzyme. Okay. Number 6 will be reuptake. Number 6 will be reuptake. You can see here the norepinephrine uptake and reuptake again and come back to the fascicles. So we have 6 steps for the norepinephrine. Number 1, synthesis. Number 2, uptake into the fascicles. Number 3, release the norepinephrine from the fascicles to the synaptic cleft and affect the receptor. Metabolized receptor could be postsynaptic receptor, presynaptic receptor, metabolized or reuptake. So synthesis, uptake, release, bind to receptor, metabolism, and reuptake. All these represent the effect or the pathway of the norepinephrine in the neurons, and in the presynaptic neuron, postsynaptic neuron, and the synaptic cleft. So the question now we ask ourselves, what are the clinical application of this steps here? Synthesis, uptake, release, binds to receptor, metabolism, and reuptake. What is the clinical aspect, the clinical application? Do you have any clinical application? Okay, so we can try to figure out what are the clinical application. As you can see here from the beginning, we have medication called clonidine. Clonidine stimulate alpha-2 receptor. So clonidine stimulate alpha-2 receptor. You can see alpha-2 receptor here. This medication used for treatment of blood pressure for patients suffer from hypertension. And this is the first medication, clonidine, Catabres, the brand name. Okay, then we have reserpine. Reserpine, another medication, not in clinical use, not very rare in clinical use, but is available as medication, reserpine. And you can see that reserpine block or prevent uptake of dopamine by the fascicles. So does not allow dopamine to enter the fascicles. So reserpine, we understand the mechanism. Reserpine inhibit the uptake of norepinephrine by the fascicles. Number 2. So the first medication, clonidine, used for patients from hypertension. Yes, and the second medication, reserpine, block dopamine receptor, not block dopamine transport to the fascicles. Okay, next we have dopamine. You can see here dopamine stimulate the beta receptor in the heart. For this reason, dopamine stimulate the heart. Dopamine could be used for the patients from shock, for example, treatment. Okay, propranolol. So dopamine stimulate beta receptor. Propranolol block the beta receptor, and we can use it for patients from angina, myocardial infarction, and other cases, cardiac arrhythmia, for example. We have several cases. So now we are discussing clinical application of norepinephrine. We have reserpine, we have clonidine, we have dopamine, we have propranolol. Okay, moving. Okay, it's phenylephrine or phenylephrine stimulate, as you can see the plus here, stimulate alpha-1 receptor. Stimulate alpha-1 receptor lead to the vasoconstriction. Vasoconstriction lead to the increased peripheral fascicular resistance, increased blood pressure, and increased risk of hypertension. So phenylephrine could be used for patients suffer from severe hypotension, and could be used as emergency medication for the severe hypotension because epinephrine increases blood pressure. Okay, prazosin. So phenylephrine stimulate alpha-1 receptor. Prazosin is a medication block alpha-1 receptor. Prazosin decrease blood pressure and used for patients from hypertension. Okay. And at the same time, they found prazosin available in the prostate. For this reason, we use for patients from benign prostatic hyperplasia. So now we have several medication in this list here: reserpine, clonidine, dopamine, propranolol, phenylephrine, prazosin. So if someone asks how reserpine work, reserpine block the uptake of dopamine by the vesicles, and reserpine could be used. It's not very rare to use. Now it's used for hypertension. Clonidine stimulate alpha 2 receptor presynaptic. Dopamine stimulate beta receptor. Propranolol block beta receptor. Phenylephrine stimulate alpha receptor, alpha 1 receptor. Brazosin block alpha 1 receptor. Now the question, what are the clinical application of the medication on the norepinephrine pathway? Okay, another last effect of medication or like substance on the norepinephrine synthesis and release is very important to mention there. We have another part. We have the cocaine and imipramine. As you can see here, cocaine and imipramine inhibit reuptake. So inhibit reuptake of norepinephrine. So what happened here? This medication inhibits reuptake of norepinephrine and dopamine, and we need to discuss what happened there, why the people become addicted on cocaine and some other medication according to this pathway here. Okay, so regarding the explaining why the cocaine and imipramine affect the norepinephrine, you can see it here. Let me draw it in the blue color here. This is a let me do it like smaller. Okay, smaller here, like this one. Okay, this one. Fine. So we have the branch here. This is a norepinephrine branch. Okay, norepinephrine. Then we have the pathways. One of the pathways will be reuptake. Another pathway will be binding to the alpha 2 receptor. Another pathway here will be metabolized by the catechol transferase, monoamino oxidase metabolism. So number 3 will be binding to the alpha 1 receptor and binding to the beta receptor. This one will be the postsynaptic. This one presynaptic. Okay, so you can see the fate. Here we have reuptake. So we have several pathways, and we already represent the medication effect. We are not going to present it here again. So you can see the flow here, or the pathway for we have several pathways, and this is number 1, number 2, number 3, and then we have number 5. So we have several pathways. So cocaine, let me clean it. Cocaine, imipramine inhibit reuptake. So what happened if you inhibit reuptake? We have 3 pathways here. So if you inhibit reuptake, you can imagine here. So I will go with the like different color. I will try to do like a green one. Okay, so when you inhibit reuptake for cocaine, by cocaine and imipramine inhibit reuptake, when you inhibit this pathway, this will be reflect as a compensatory mechanism to increase release of norepinephrine in the synaptic cleft and binding to the receptor. So this will increase activity of alpha and beta receptor, increase. So this will not only affect the norepinephrine. So here in this pathway here, we have not only norepinephrine, you remember that we have dopamine. Okay, so cocaine, when you prescribe cocaine, or when you take the cocaine like as substance, a legal substance, cocaine will increase or enhance both norepinephrine and dopamine. And this, therefore, our body will rely on this medication to enhance these two mediator in our body. So we depends on this medication and create addiction. So because our body will stop releasing this mediator unless you take this cocaine. So when you take cocaine, our body stop producing until you take cocaine. When you take cocaine, our body start response. Then our body produce tolerance. That means we need more cocaine. to produce the same effect. So we have the dependence, could be psychological dependence, could be physical dependence. Okay, we're done with the norepinephrine pathway, synthesis, uptake, release, binding to receptor, metabolism, and reuptake. And we discussed medication affect this pathway, several medication. Okay, regarding acetylcholine, we are not going to speak in depth here because the next lecture will be cholinergic agonist. We are going to discuss the pathway in details, but we have similarity here. We need you to remember the steps. We have the same 6 steps. Start from synthesis, uptake, acetylcholine release. Then we have bind to the receptor, metabolism, reuptake. So the situation here, the acetylcholine synthesis start from the choline, enter the cells, start from the choline, enter the cell with the co-transporter with the sodium. The choline with the acetyl coenzyme A will lead to the formation of acetylcholine. The acetylcholine will enter the vesicles. Then the acetylcholine will release from the vesicles. The acetylcholine bind to the receptor. Could be muscarinic receptor, nicotinic receptor. The other option will be binding to the presynaptic receptors. The other option will be acetylcholine metabolized by the enzyme called acetylcholinesterase enzyme, acetyl coenzyme A enzyme, okay, to the choline and acetate. The choline will be recycled again, reused again. We call this one reuptake. So you can see here the acetylcholine affect 2 main receptors, muscarinic receptor and nicotinic receptor. Some example for the medication, pilocarpine, we discussed it already with you when you speak about the eye. Then we have pilocarpine stimulate muscarinic receptor. On the other hand, atropine block the muscarinic receptor. And we discussed the clinical application of this one. Another important substance available in the nature, we have spider venom. We have spider venom when someone get bite by the spider, and the spider venom spread in our body, in our nervous system. This will stimulate enhanced release of acetylcholine. So spider venom enhance release of acetylcholine. On the other hand, we have botulinum toxin and the brand name Botox, and you can see the Botox here inhibit release of acetylcholine. Okay, I will go with you back to the slide. If you remember, nicotinic receptor in the skeletal muscle lead to the contraction of skeletal muscle. So acetylcholine in skeletal muscle lead to the contraction of skeletal muscle. That's number one side. Botulinum toxin inhibit release of acetylcholine. That means inhibit effect of skeletal muscle contraction. They will relax skeletal muscle contraction. So Botox, they inject Botox in the skeletal muscle and cause relaxation. The Botox, botulinum toxin used to relieve the wrinkles around the eyes, or for some facial wrinkles. We can use Botox for these purposes here because inhibit skeletal muscle contraction and cause relaxation. Could last for 6 months roughly. This will conclude our first part of introduction and the principle of autonomic nervous system. As a quick summary for what we covered in this lecture today, we start talking about the nervous system as 2 parts. We spoke about the central nervous system and peripheral nervous system. Then we move to the autonomic nervous system, somatic nervous system. We discussed the type of receptor like nicotinic receptor, muscarinic receptor, alpha receptor, beta receptor, and the subtypes. Then we mentioned the effect of these receptors on the GQ protein, GI protein, GS protein. Also, we discussed what type of receptor we have in the GI system, and we consider like guts brain. And you can see there we have more than 10, 12, 15 mediators in the GI system: serotonin, bradykinin, substance P, adrenaline, epinephrine, a lot, acetylcholine. We have a lot of mediator there. Then we discuss the origination or originate of parasympathetic and sympathetic neurons. We discuss the cranial nerve. We discuss the thoracic nerve, lumbar nerve, and then we discuss the sacral nerve, and we discuss the preganglionic neuron and postganglionic neuron. Then we look on the ganglia. What receptor do you have in the ganglia? We discussed it already. We move to the characteristic of these receptors. So, for example, when you talk about M1, M2, M3, and NN and NM, all these receptors belong to the cholinergic receptor. So we need to remember which one work on GI protein, GS protein, or GQ protein. Then we discuss another concept called reflex arcs, when the patients are from hypotension or decreased blood pressure. Then we went through the norepinephrine pathways that start from tyrosine until releasing the norepinephrine or dopamine. And we brought maybe the last part for this one. We discussed cocaine, and we explain why people become addicted and dependence on cocaine, because of our body rely on the outside sources to increase norepinephrine and dopamine. And according to this pathway for norepinephrine and acetylcholine cholinergic neurons, we discuss several clinical application of drug in clinical use. So, for example, we discuss phenylephrine, pilocarpine, we discuss what else? Reserpine, we discuss clonidine, we discuss propranolol, dopamine, a lot of medication according to the pathway of norepinephrine and acetylcholine. This will conclude our important lecture on autonomic nervous system, and I hope you enjoy this lecture, and see you in the second part about the cholinergic agonist. Thank you so much, and have a great day.